नमस्कार, सत श्री अकाल, आदाब, गुड मॉर्निंग, गुड आफ्टरनून एंड गुड इवनिंग जहां से भी आप हमें सुन रहे हैं. थैंक यू फॉर जॉइनिंग आवर लाइव सेशन. माय नेम इज कुंजन मवार. हमें आपके होस्ट और दोस्त फॉर टुडेज एफपी सेशन. So if a certain human being has COPD, how does COPD affect our daily lives?
So what we look at is the three major things, right? So shortness of breath, cough, and sputum. So if you think about these three, the way it limits a person's activities of daily living is what we call it as. So physical activity. So the person is not able to walk for long distances. They get winded. They have to stop. They're not able to do daily chores. They get deconditioned because they're not able to exercise. So the lower extremities, the strength, they start getting weaker. They're not able to walk uphill. They're not able to lift anything heavy, carrying groceries, or carrying their laundry basket from the basement. So these are things which physically they get challenged with. But this happens, now they are socially, they're not interacting, they're staying at home, away from people. They start getting anxious, they start getting depressed, their mental health is affected, they slowly start losing the pleasure of activities of daily life. Sleep gets affected. There's kind of like an overlap of COPD and sleep apnea. So they're not able to have a good, refreshing sleep, which in turn affects other vital organs, blood pressure going up, irregularities of the heart. So these are kind of, in general, how it starts affecting. And also socially, they're trying to avoid people because they're constantly coughing. They don't want to be seen coughing. They have to have oxygen. They're not impressed to wear oxygen and come out, right? So they feel it as a taboo. People will think differently when they look at them. So that's how it kind of affects their daily life. It's unfortunate. So that's why it's extremely important to understand and try to treat them as quickly as possible. I hope that answers.
So,
yeah.
No, wonderful. So, if I have to boil it down, so a person who is not able to do regular chores, like you were saying, lifting the groceries or walking a little bit, not able to sleep properly, not able to socialize, anxiety, depression. So those are basically the common ways how a COPD can affect a person's life.
Absolutely. Yep. You're absolutely right.
Okay, perfect. So does it also affect on somebody's life? Like, what's the life expectancy of a person suffering from COPD?
I won't go too much in detail, but COPD has different stages, and what we try to do is there's a specific index which is called BODE index. It's BODE. Where the acronym B stands for the BMI, the body mass index. So if someone is very thin, very frail, that scores a point. That's bad for them, right? If their BMI is more than 21, that's good for them. So in the board, the B stands for BMI, O stands for obstruction. So how bad is COPD? So we ask them to do a breathing test where they blow into a machine, and we look and see in that first second, how much air are they being able to expel out? What is the lung capacity? So based on that, we grade them as mild, moderate, severe, or very severe. So that is the obstruction part. And then the dyspnea, or the shortness of breath, is what we talked about. Are they comfortable when they're walking or exercising? Do they only get short-winded when they're walking uphill? Or is it even on level ground? Or even if they have to, dress or shower, they start getting winded. So those have different points as well. And then last is their exercise capacity. E is the exercise capacity. Are they able to walk 100 yards or 150 yards? Yes or no? And if not, then they score 3 points. So bottom line is anyone can score anywhere from 0 to 10 points on this BODE index. So if they score very high, if they have 10 points, that means their 4-year survival is very dismal. It's less than 20. It's about 18%. Versus if they don't score any point, if there is 0, if they are really good, or 0 to 2 points, that means they have excellent life expectancy. They're more than 80% survival in 4 years' time. So that's kind of how we use. There are other complex things to use too, but these are some of the simpler ones.
Okay, so people, if you're listening, 0 to 2 is the magic number. Make sure that you are between the 0 to 2.
You got
okay,
it.
thank you. So you touched upon smoking. So what about the people, like not everybody smokes, a good chunk of people smoke, but a good chunk of people don't smoke. So, you know, in asthma, they say if you inhale the smoke, like someone is smoking near you and you are right there. So what about COPD? Can a non-smoker be a COPD, or can they get COPD?
Absolutely. In fact, that's like I said, not everyone who smokes develops COPD. It's about 30 to 50% of people who could get COPD if they are smokers. But 80% of COPDers are smokers. Majority of them are smokers, either directly or indirectly, in most of the countries. Having said that, there are, like, for example, if you take India, air pollution, using different types of biomass fuel. So, like, for example, burning wood to cook or to heat, things like poorly ventilated areas. If you're inhaling a lot of fumes, dust, certain types of coal, animal dung. So those are used for different reasons in order to cook or heat the place. So those may be affecting, those may be causing COPD. So some of the states, like for example, Jammu and Kashmir, Haryana, Himachal Pradesh, Kerala, all these places have shown higher incidence, maybe more farming, maybe there is more amount of using biomass fuel in those areas. But occupational exposure, someone who's constantly spraying pesticides or constantly spraying different types of chemicals, they are exposed to different types of coloring agents, or inhaling fumes while they're cleaning. So these could also be causing COPD. One of the things which we talked about was the genetic deficiency, alpha-1 antitrypsin. That's another one. Socioeconomic status. So if there's a lot of pollution, crowding, poor nutrition, recurrent infections, they all come together and could be contributing to COPD. So these are other things which can cause other than smoking.
So if you say by cooking, right? If somebody is cooking and they don't have access to the gas range or the cooking range that we have, but yet they are using coal and cow dung to cook, what precautions can they use? Because that's part of their livelihood, right? So what can they do?
Absolutely. So, so the things which they could potentially do is, one, if possible, eliminate it. If not, the other option is try to be in a well-ventilated area. Maybe having an exhaust fan in that area. Maybe not limiting, you don't have to be in front of that place all the time. Put it on, move out of that place, not inhale the smoke, and come back when you're ready to get it down, right? So things which you can do to minimize exposure. So those are some of the things which you could always do. And of course, maybe wearing a mask now, that's the common theme for everything. So wearing a mask would be the other possibility which you could go with.
Okay, wonderful. Thank you. So that's actually good to know that we can continue with our daily lives, but with a little precaution, the thing can be, we can eliminate having a COPD. So for people like me who doesn't understand too many medical and fancy terms, I would also think COPD as asthma or asthma as COPD. So what is the difference between COPD and asthma?
Very good question. So you're right. Both of them, the symptoms are very similar. It's cough, shortness of breath, wheezing, not necessarily as much sputum with asthma, but in general, asthma is more like a younger generation, people who are less than 40 years of age. They are not necessarily smokers. They don't cough up a lot of phlegm. Atopy, which is kind of like a term we use for genetic tendency to develop allergic type of reactions. So allergic rhinitis, constantly runny nose, seasonal allergies, asthma, all of these kind of come together in that environment. Usually asthma is not progressive. The symptoms tend to resolve, but they tend to get triggered by those, the change in season or the pollen, whatever is triggering it. If you do that breathing test normalizes in between the attacks. The type of cells which are involved are different. Eosinophils are what is typically seen in asthma, right? Versus COPD is the older, more than 40-year-old. It's a progressive disease. People are getting more and more winded. They're not coming back to normal. They are usually smokers, a lot of sputum production. So that's the typical presentation if it is more a COPD rather than asthma.
Asthma. So if somebody comes to you and they thought they had asthma for the longest, but when you do the test, you can actually tell them it's not asthma, it's actually COPD.
It's sometimes difficult. Sometimes there is a overlap of asthma and COPD. So they may be starting off early on as asthma, and that slowly they start progressing into the COPD. The good thing is both are treated very similarly. So that helps. So, but that overlap is sometimes possible, and it's difficult. They are labeled as asthma forever. But in general, if they've never smoked, asthma is much more a possibility.
Got it. Okay, that's a good distinction. So
yeah.
A non-smoker, asthma, smoker, definitely COPD if it's prolonged. Okay.
Yeah.
Okay.
Yep.
Perfect. So thank you for that wonderful information. I am definitely getting too much enlightened right now, and I hope that our viewers and listeners are also getting enlightened. So what is the best treatment option? First of all, let me ask you, is COPD treatable? And if it's yes, then what is the best treatment option for COPD?
Sure. So there are so when we talk about treatment, there are two things we don't want to confuse. One, can we cure COPD, or can we stop COPD and completely make it back to normal? The answer is no. Unfortunately, there is no cure to it. However, there are different treatment options that are available. So I won't go too much into, again, the details of the treatment part, but in general, there are certain goals we have, right? So those goals could be, how can we reduce the symptoms so the patient's quality of life is improved, their exercise capacity is improved, right? So reducing symptoms, reducing flare-ups. Flare-ups is one thing which causes the lung function to go down very quickly. So if we can reduce flare-ups, reducing hospital admission, those are very good goals. If you are able to improve survival, that's a very good goal. So these are things to do: symptoms, quality of life, exercise capacity, improving that. So these are things which we typically focus our attention on. So if we are looking at what is the treatment, inhalers, that's and there are different varieties. Some which are maintenance, which we use on us every day, irrespective. And then there are those emergency inhaler, which gives immediate relief. Typically seen in movies, right? The last inhaler is gone, and the son or daughter is running to the pharmacy and trying to buy one, and while the mom is having trouble breathing. So that is the rescue inhaler. So what they typically do is the airways, the tubes are narrowed because of inflammation, and when they use the inhaler, those tubes open up. So when they open up, more oxygen is getting in, and the secretions and secretions which are there inside are able to come out completely. There are certain medicines which we also use which can break up the mucus. which can reduce inflammation, like steroids. Inhaled steroid is something which reduces inflammation. Oxygen, giving them oxygen in the right setting helps in improving oxygen, which gets into the lung and therefore into the blood. There are certain types of ventilators that can be used at home, certain surgical options. If a portion of the lung is not working, if we take out that part of the lung, that can help in getting oxygen to the right part of the lung and not the worst part of the lung, right? We can put certain types of valves inside, one-way valve. So it prevents oxygen from getting into the bad lung and helps in directing it to the more efficient part. So different things which we can, and of course, transplant, lung transplant. If the whole lung is not working, take it out and put a new one, right? So easier to say, but these are treatment options which are definitely, which are available, and they are geared towards different patients.
Well, that's actually good to know. So if someone has COPD, there are treatments, even though we can't go back and not have COPD, but there are still treatments that would actually add value. So that's always a good news to know. So with that, I'm going to go to my next question. So I saw a number floating around, like a 16 million, that 16 billion people are affected by COPD. So how do I know? Like I don't have any issues. I can walk, exercise, I can sleep, all the stuff that you described that could actually trigger and tell you that you have COPD. But how do I know that I am part of that 16 million?
Sure. So that's a very good question that you're asking. So two things I want to clarify. So the 16 million is specifically in US. So these are proven in United States. If you look across the world, there are millions of people who are yet to be diagnosed. So, so the recommendations are, if you don't have any symptom, is it worth doing a screening test, right? So say you take a person who's a smoker and has smoked every day for the last 30 years, but has absolutely zero symptoms. Their guidelines say you don't have to screen them to prove whether they have COPD or not, because by detecting them early, you're not preventing progression. You're not reducing the progression of the disease. So you don't have to know whether you are in that 16 million or not, frankly, if you're asymptomatic. So if you're really doing good, you don't have to worry about it. The way I think about it is, do I know someone? I am healthy, but do I know someone, my parents, my grandparents, my uncles, my aunts, my family, my friends, anyone who is having those type of symptoms? And can I put them as, okay, is that person having COPD? Should they get tested? And probably try to help them in that way. That's how I would see that. Yeah.
Okay, that's a wonderful way to put at it. So thank you so much. So, and a follow-up question on what you were describing. If I know someone who's a smoker but doesn't show all the symptoms, might have few symptoms here and there, is there a particular age that after that particular age one should definitely get screened if they have been smoking?
No, there is no age factor at all, because if you have symptoms between those three symptoms we talked about, if you are if someone is a smoker, irrespective of, now if you take the way to think about it is also, if you have a very elderly person, like say a 90-year-old, there's no point in trying to do a test on to prove they have COPD. At that point, it's better to treat them assuming they have it, rather than, it's kind of like, should you do a stress test on a person who's 90-year-old to prove they have a blockage in the heart, right? So we don't like to do that unnecessarily. Now that 90-year-old may be having absolutely wonderful functional capacity, in which case, they may be very healthy and they're playing golf or they're doing different other things. And that person, yeah, sure, absolutely, we should be able to diagnose it and prove this is not something related to the heart or something else, and this is actually lung driven, and then treat accordingly.
Okay, got it. So let's switch gears a little bit. I'm gonna be still continuing the topic of COPD, but let's talk about current situations, which is COVID. We have been living and breathing for last 18 months or a little over 2 years now. So what are your thoughts on, so a patient with asthma or COPD, how easy it is, or are they the ideal targets? Like, do you think they can get COVID they can get COVID compared to the other people who are not asthmatic or COPD?
So one thing is, so as we know, majority of the deaths in COVID, more than 80%, they are in adults who are more than 65 years. Having said that, CDC again identifies certain risk factors. People who are immune compromised, who are transplanted, or high body mass index, more than 40, pregnant, chronic renal problems, chronic heart problems, or severe heart problems, I should say. COPD is also in that risk factor where the disease severity. So the patient, if they get COVID, that could potentially be severe COVID. So COPD and other chronic lung conditions, including smoking, even whether they're smoking now or previously, that puts them at a higher risk of a more severe COVID. Asthma, on the other hand, is a possible risk factor. It's not definitive, though. At least this is as of now. I mean, it may change depending on future studies and whatnot. But irrespective of, so if it is mild asthma, maybe not. Maybe if it is a very severe asthma and they're chronically on steroids, maybe that is, and again, I'm presuming here, but that may be a risk factor in future. As of now, COPD is considered as a risk factor, not necessarily asthma.
Okay, wonderful. So if you are COPD, make sure you take all the precautions, and a little more goes a long way. So what extra care a COPD person should take during this pandemic? We keep seeing new variants coming in, and every variant has a different side effects and different stuff that they bring with them. So what extra care a person can take so they don't get COVID, or if they get COVID, they recover faster?
Sure. So first thing is symptoms. So if you have worsening symptoms, but also worsening cough, shortness of breath, and sputum, but you also have fever and say like a viral prodrome, so body aches, headache, loss of smell, loss of taste, any of those warning symptoms, definitely get tested. That's the first step, right? So you always want to get, whether it's a home test or a PCR, that's a different story, but it's important to get tested. Don't change your inhalers. Continue what inhalers you are already using. There's no need to change them. Having said that, there are certain types of inhalers which we call as nebulizer, which we use in some scenarios. Maybe not a good idea to use a nebulizer because that aerosolizes everything. So if someone develops COVID, that COVID can spread into the entire room. And therefore, if anyone walks into that room or opens the door, it can percolate and affect other family members as well. So nebulizer is not a good idea to use in general. Testing. So you don't want to unnecessarily visit the hospital, get that spirometry, that breathing test I was talking about. Now is not a good time to get tested unnecessarily, because you're exposing yourself unnecessarily if you're doing the test, or say you're getting an X-ray or CT scan. Now is not a good time to do any of those if we don't really have to. Common sense things, again, masking, social distancing, all those hand wash, all those obviously are important. But I would say the other important things are stay in touch. Make sure you talk to your friend. Make sure you talk to your neighbor, your family, right? Anticipate problems. What if me or my better half, or kids or whoever it is, if someone gets it, what are we going to do? Where am I going to take them? Do I have a bag ready, packed with what supplies I need? If you're at home, make sure your inhalers are updated. Make sure you have good stock of them, right? Do teleconsults, come on to e-consults, the eGlobalDoctors, right? Our platform, talk to 24/7 coverage. So this is the best platform to do that. So having these type of checklists is extremely important in these times. So that way you're protecting yourself and protecting others as well at the same time.
Well, wonderful. Thank you so much. I know that I have learned a lot. So with that, we will be wrapping our today's session. So eGlobalDoctors is one complete healthcare platform solution for all medical related issues and questions. And maje ki baat hai that you have these services available to you at your fingertips without breaking your banks and without even driving. It's all in the comfort of your living room. You can find and connect to eGlobal on LinkedIn, Facebook, Instagram, Pinterest, YouTube, Twitter, all the old-fashioned way, eGlobalDoctors.com. If you are an Indian origin, folks living in US, if parents are visiting from India and looking for medical consultation, well, look no further. eGlobalDoctors has your back. Access to doctors from USA and India, their specialties are included. I will be telling you some, but not limited to internal medicine, cardiology, orthopedics, oncology, pediatrics, and many more. Prescription will be provided. Response time is 1 to 3 days. Family members can participate live via video consultation from any part of the world. Consultation is up to 30 minutes. In-app messaging with doctor after consultation, ID and portable healthcare passports. So before I let you go, Dr. Raj, any word of wisdoms you want to share with our viewers?
No, I think we talked a lot about COPD and the common things to do. So I also want to thank you, Kunjan, for interrogating me, interviewing me, inviting me here. And definitely, I would like to thank the platform, eGlobalDoctors platform. A huge thanks to Arya and all the volunteers who are working really tirelessly. The administrators, the eGlobalDoctors, Dr. Srini, and rest of the physicians providing such wonderful guidance. So really, really appreciate all that you're doing, and thank you to all of you.
Well, thank you. There you have it. This is RJ Kunjan signing off. See you. Sayonara. Keep smiling till we meet again and stay safe. And Dr. Raj, thank you so much for the wonderful, informative session. Have a good evening. Namaskar.
Thank you. Take care. See you guys.